So we are going to be, to frame this a little bit further, we're dealing with the same problem. This is a slide from the Kaiser Family Foundation. It was released including 2020 premium information. This is showing what employers are paying and what employees or workers are paying. And as you can see, it's just been increasing. And now an average family in the United States is paying over $21,000 in premiums, which is just staggering. And I don't know where it stops. This is truly a non-sustainable path. As many of you are in open enrollment right now, I know my health insurance went up 6%, and I have probably one of the best plans in the state. And every year, we just can't have prices going up on the commercial side. So we will be talking a lot about that over the next couple of hours. Next slide, please. So in addition to premiums going up, it's important to understand the impact on people. And so while workers' earnings have gone up a little bit over time since in the past 10 years, family premiums, as we mentioned, have gone up quite a bit to over $21,000 per year. But look at the deductibles. This is the out-of-patient packet expenses for patients. So they're just having to spend a larger proportion out of pocket. Next slide, please. So at this point, I'd like to pass the torch over to Chris Whaley. He's a PhD policy researcher from RAND Corporation. He was co-author on RAND 2.0 and lead author on RAND 3.0 and lead author on the coming RAND 4.0. Chris, thank you so much for being here from your hotel on the beach.
Thank you, Gloria. It's always fun to present to this group. I just want to reiterate what Gloria said in two fronts. So one, this is just an insane time for the country right now, and what I hope many of us, or I think many of us hope that at this point we've had things under control, but looks like things are spiraling a little bit. And then the other thing that I just want to reiterate that Gloria said is that just to emphasize the affordability issue in healthcare. Right now, we're largely as a country and as an employer community paying for worker pay increases in healthcare dollars rather than take-home wage dollars. And that's something that I don't think is necessarily sustainable for both employers, but especially workers and their families. So with that in mind, we were really excited to look at some issues around affordability, and the key component of affordability is prices. Next slide, please. And so, as I said earlier, it's really great to come back and talk to this group, really because the studies that we've done on hospital prices is really the brainchild of Dave and Gloria. And so a couple of years ago, Dave and Gloria reached out to my RAND colleague, Chapin White, and had a question that I think many employers have, which is essentially, is the dollars that we're spending getting us actual value? And can we be doing more as employer purchasers to make sure that we are getting appropriate value for our healthcare dollars? That's a question that it seems like it should be actually easy to answer, because this is a collectively across all employers about a $1.2 trillion industry. But it is insane to think that despite the size and the importance of the healthcare market for employers, we really just don't have a good sense on prices. And so what my colleague Chapin was able to do, again with a lot of work and effort from EFI, was to collect data from employers in Indiana and to provide price information for about 120 hospitals in Indiana. This is I think a really groundbreaking study for employers in Indiana, and really highlighted just the range in prices across the state of Indiana that Indiana employers, and more importantly, their workers are paying for healthcare. After we did the study, which we call RAND 1.0, that just looked at Indiana, kind of word got out, and there were many other employers across the country that saw the information that you as Indiana employers were able to get, and essentially said, we want to know the exact same information. We want to know for us as purchasers, how do we compare to or how do our prices look within our markets? At the same time, many Indiana employers saw the range in prices in Indiana from RAND 1.0 and were really asking themselves, how do our prices compare to other prices in other states and other markets in which we compete or we have competitors? And so with that kind of motivation, Chapin, myself, and also Gloria and Dave were able to go out and get a lot of interest from a broad coalition of employers, both individual employers, purchasing organizations, and a couple of state all-payer claims databases. We were able to use that motivation to expand our sample from 120 Indiana hospitals to about 1,600 hospitals from 25 states across the country. What we did in that study is highlight the range in prices both within states and then also between different states. One of the really relevant findings from that study was that when we look at the 25 states in our sample, Indiana actually had the highest hospital prices out of all of the 25 different states. We released that study in May of last year, and it was great to come out to Indianapolis and to present and share those results. Next slide, please. And with the kind of the attention that study got, there was a lot of interest from other employers and other purchaser communities, and so we were actually able to expand our study quite a bit in the RAND 3.0 study that we released last year, or rather last month, or I guess 6 weeks ago. In that study, we were able to get data from all 50 states. In our analysis, we dropped Maryland because they have a unique all-payer rate setting model. And we were able to look at hospital prices for about 3,100 hospitals across the 2016 to 2018 3-year period. For that study, we not only expanded in scope the number of states and hospitals that we were able to look at, but in doing so, we're able to look at a much larger volume of claims and a much larger chunk of healthcare spending. For the RAND 3.0 study, we used data from, again, self-insured employers as kind of the backbone of the study. We also got data from 6 state all-payer claims databases and also from a few health plans from across the country. This study, again, was released in September, and as Gloria mentioned, we had a really nice virtual conference to share those results. And the study, like our other studies, was funded by the Robert Wood Johnson Foundation, and then also by several participating employers. Next slide, please. And so I think the results of the RAND 3.0 study really continue to push what we know about hospital prices and what employers and their families are paying for hospital care. One of the things we highlighted in kind of the top line result is that prices for the privately insured population continue to increase year over year. And so, for example, if we go back to 2016, employers in our data were paying 224% of Medicare for hospital prices. That number increased to 230% in 2017 and increased quite a bit to 247% in 2018. Now, keep in mind that this increase is actually on top of all the price increases and inflation increases that the Medicare system bakes into their payment models. And so on top of a steadily increasing Medicare payment rate, the gap between employers and Medicare is increasing by about 5% per year. Next slide, please. We again found that prices varied pretty widely. One of so this chart shows across the states that we looked at just the range in prices. And so this is kind of our most holistic view of prices, where we group both inpatient and outpatient services, but then also include facility and professional fees. And so in a hospital bill, or if a patient goes to hospital, they get a bill for facility care, which accounts for the revenue that goes to the hospital, and then also a professional bill that accounts for services provided by physicians and other professionals. And so in our measures, we lumped all those together to have kind of a aggregate measure of hospital prices. And what we find is that across our states, there's still a tremendous amount of variation. And so if we look at the low end and look at states like Arkansas and Michigan, the red circles denote both inpatient and outpatient prices combined. We find that prices in India, or rather in Arkansas and Michigan, are actually below 200% of Medicare. At the upper end, states like South Carolina and West Virginia are around 350% of Medicare. So just across the country, there's about a 2x variation in hospital prices across states. If we look at Indiana, we find that they were actually ranked 6th at 304% of Medicare when we combine inpatient, outpatient, and also lump together professional and facility fees.
Chris, could you clarify what the squares, circles, and triangles mean again, just for everyone's benefit? Thank you.
Sure. Right. So as I mentioned earlier, we, in our kind of top line number, group together inpatient and outpatient services. And so that's what the red circles mean. But we also, in the same plot, chart inpatient services. So that's the gray circles, and outpatient prices, and that's the triangles. And so I think the importance of plotting inpatient and outpatient services is that you can see that there's a very wide range in prices and the kind of the consistency of prices across states. So in some states, outpatient services are more expensive than inpatient services. For some states, it's the opposite. For some states, there's a pretty wide gap between inpatient and outpatient care. And for some states, they're actually pretty close together. And so I think the main takeaway is that if you're in any of these individual states, it's really important to not think about kind of the hospital sector, the healthcare sector as a whole, but you actually really need pretty granular data on individual hospital prices for specific services, or service lines rather. And just reflecting on this chart, one of the things that we found in RAND 2.0 that was really surprising is that our most expensive state in just the 25 states was Indiana, and our least expensive state was Michigan. Here we find roughly the same pattern where Indiana is near the top and Michigan is second from the bottom. And so I think as you're a Indiana employer, I think that's a relevant comparison, because you have two neighboring states that are relatively similar in terms of population size, demographics, patient composition, and mix of urban versus rural areas. But we see that Indiana is among the most expensive states in the country, and Michigan is among the most affordable states. Next slide, please. As I mentioned earlier, we in our kind of top line measure included both facility and professional fees, but what we've also done is separate how much facilities earn relative to Medicare and professionals relative to Medicare in each state. And so what we can see is that in some states like Alaska and Minnesota, professionals are making quite a bit more than facilities relative to Medicare. But on the flip side, in states like Indiana, which is actually tied for second highest with West Virginia in terms of the gap between facility fees and professional fees, facilities are making about 200% more than Medicare relative to professionals. And so if we look at Indiana in particular, the price relative to Medicare for facilities is above 300% of Medicare, but I believe professionals are around 130%. And so I think as we're thinking about the Indiana market, what that really implies is that when you're thinking about where's the money in the healthcare spending in Indiana going, the bulk of it is going to hospitals as a whole, and actually a relatively small portion of it is going to doctors and other physicians. Next slide, please. We continue to look at quality in our study and looked at both quality using data from CMS quality stars. And so this is a CMS model that has designed ways to group hospital stars from 5 stars. And so this is the highest level quality to 1 star, which is the lowest level of quality. We also use some data from the Leapfrog group to look at hospital safety scores and get about the same result. Our overall finding when we look at quality in the relationship between hospital price and quality is that there is some relationship between price and quality. And so there tend to be more 5-star hospitals in our highest price group. And so to look at price groups, what we've done is we've categorized hospitals as those with low prices, those with medium prices. So the low prices are those with prices below 150% of Medicare. The medium are those with 150 to 250% Medicare. And the most expensive hospitals, or our high price hospitals, are those with prices above 250% Medicare. And so we do find that there are more 5-star hospitals in the high price group, but there are also several low-star hospitals in the high price group, and many 4 and 5 stars hospitals in the low price group. And so while there may be a small relationship between price and quality, there are many low price hospitals that have really high quality, and many high price hospitals that have very low quality. And so similar when you're thinking about price, it's important to not just think about hospitals as a whole, but to actually have really good granular data on price and quality for individual hospitals. And so in our supplemental material that's available on the RAND website, we have for each hospital, and in particular hospitals in Indiana, their price relative to Medicare, and then also their CMS quality stars. Next slide, please. One of the big pushbacks that we got when we did the RAND 2.0 study last year was from the hospital side of the story, that we as hospitals have to charge high prices to our employer community to account for underpayments from Medicare and Medicaid. Now, there's kind of maybe not a lot of justification for that if you think about it a little bit. Many companies, and I'm sure many employers on the phone, sell products to different customer bases at different prices based on segmenting the market and how much each employer is willing to pay, or each customer is willing to pay. And hospitals in some sense are no different. But we wanted to take this to the data and actually use our data to see if the story actually held up. And so if the story or the hospitals are charging high prices to employers and other private insurers is true, then what we should see is that hospitals that have lots of Medicare or Medicaid patients are the ones that are charging the highest prices, and hospitals that have relatively few Medicare or Medicaid patients are those that are charging lower prices. And so what we've done here is on the left-hand side, on the vertical axis, is plot the price in our data for each hospital relative to Medicare. And then on the bottom axis, we've plotted each hospital's share of patients that come from Medicare or Medicaid. And so again, if the story is that hospitals that are charging high prices have to charge high prices to account for having more Medicaid or Medicaid patients, then we should see some sort of relationship on this line that's roughly a 45-degree line. Instead, if you look at this chart, it looks to me is essentially a random scatter of dots. And when we actually kind of look at the statistical relationship, we find no relationship between a hospital's share of patients that come from Medicaid or Medicare and that hospital's price. And so I think that the main takeaway is that it's true that hospitals do charge different prices to employers and private insurers than they get from Medicare and Medicaid, but it's not the fact that differences in Medicare and Medicaid payment actually cause differences in employer payments. The other kind of way to think about that is that hospitals would charge employers high prices regardless of what they got from Medicare or Medicaid. And so if a hospital is charging a high price, It's due likely to things like that hospital has lots of reputation, it's in a market where it has lots of negotiation ability, or maybe it has higher quality. And those types of things tend to drive prices, not anything to do with the hospital's exposure to Medicaid or Medicaid. Next slide, please. So thank you, and happy to give to have this opportunity to give another overview of our study. And again, always great to talk to this group, and happy to turn over to Gloria to talk about the Indiana specific findings.
Excellent. Thank you so much, Chris. And we'll have some time at the end here for a few questions for either Chris or I about the RAND study. So please feel free to enter your questions into the chat box. I wish we were here in person where you could just raise your hand and ask your questions, but this is one of the limitations we do have with technology. Next slide, please. So I just wanted to let you know that the RAND 3.0 study and all of the information related to it, all the supplements, can be found at this website, employerptp.org. You can download this supplement. So all of the charts that I'm going to be showing you, here in a minute or so, are coming from this supplement. There are 115 hospitals in Indiana, and that's on the hospitals tab. There are a lot of tabs, but the second tab, which is the hospitals tab, has all 3,112 hospitals on it. They're organized by state, so you can just pull out the Indiana ones, dump them in another Excel spreadsheet, and then do your own pivot tables, however you would like to, and marry it with other data that you might have. There is also an Indiana tab further in, and that has all of the prices organized by health systems instead of individual hospitals. Next slide, please. So I'm going to go through these really quickly because they are posted on the forum website, and in the interest of time, when we have a robust agenda, I'm going to ask that everyone just download those slides and spend some time with it. But we'll go through these pretty quickly. So we wanted to compare Indiana to our neighboring states. And as was the case in RAND 2.0, we are still the highest. For orange is outpatient facility. So that's what the hospital gets paid. The green is inpatient facility, what the hospital gets paid. And blue is the professional fee, which is what physicians get paid. So that was a really unique finding that we had here in Indiana, that our professional fees are so low, and we were fourth lowest out of all of the states analyzed across the country, but fourth highest for facility fees. Next slide, please. So we've had a slide like this last year. This is Indiana and Michigan. This is looking at inpatient, outpatient, plus professional fees all wrapped together. And, our prices have been going up significantly every year. I mean, really shockingly, it's just staggering how much it's been going up, the large percent jumps. While Michigan is actually, their prices have been going down and staying flat. Next slide, please. This is Indiana hospital prices relative to Medicare using 2018 data. RAND 3.0 was a look back to 2016 to 2018. This is combined inpatient, outpatient, and includes the professional fee. So when you get a knee replacement, for example, you're paying the hospital and you're paying the physician for that knee replacement. So there are different ways you can look at it. You can say, well, what am I just paying for the knee replacement? Or the MRI, it's the radiologist plus the actual image itself. And then we've got ways where you can separate that information out. So here, if this is by health system, this is looking at, and then we added a couple of hospitals in here per request of one of our employers. So this is health systems, but then we added Schneck and Columbus Regional Hospital. And this really hasn't changed too much from RAND 2.0, except for the percentages are higher, unfortunately. Next slide, please. Now, if you want to look at central Indiana, and you can, again, if you want to look at Columbus or Kokomo or Bloomington or South Bend, Fort Wayne, you can just go to that spreadsheet and make these pivot tables. If you need any help making the pivot tables, feel free to email me and we'll gladly make tables for anyone that wants them. If you're interested in a certain geographical area, we're happy to help out. So here is central Indiana. This is facility fee prices only, just looking at inpatient and outpatient. Here we have Community Health Network East, and South, Schneck, IU Health, and North, our Community Health North, are amongst our highest. Next slide, please. And this is looking at splitting it out with facilities. So it's inpatient plus outpatient now, separated by professional fees, and then looking again at the total. I was surprised to see how big a difference there is in professional fee payment. I just thought there was a standard fee for doctors and that they all kind of got paid off of the same pay schedule, but that does not appear to be the case. So just as there is significant variability in how much the hospitals are getting paid, even within the same health system, there's a lot of variation in how much the physicians or the professional fees are getting paid. And, you know, some of these professional fees include primary care physicians and specialists. For RAND 4.0, that's one of the things we've added to the wish list per a recommendation from an employer, is they would really like to see that separated out. And so that's on our list for the next study. Next slide, please. In RAND 2.0 and in RAND 3.0, you can look at prices two different ways. You can look at them as a percent of Medicare, and that's what these, you know, prior tables have been showing you. But there's also columns for standardized price. And standardized price is important, particularly for hospitals or health systems in which they're seeing a large volume of underserved patient populations, such as the uninsured Medicaid patients, and also if they're affiliated with medical training. So if they are seeing medical residents, so it's number of medical residents per hospital beds. So essentially if they're involved in medical education. So there are two factors. So Medicare pays a base pay. Let's say for a colonoscopy, they have a base pay. And then if you are a hospital that has a lot of underserved patients that you see, you get what they call a dish adjustment. So basically an extra, a payment, if you will. And if you're providing a lot of medical education, you get an extra payment. There's been this discussion of how do we just compare apples to apples without all of the adjustments. And that's what standardized prices are. It's just that base pay, which does include how sick the patient is. So it includes something called patient acuity, but it doesn't include it doesn't include those other factors, any of the other factors that Medicare makes. So here, this is just an illustration. The outpatient prices, the columns are the exact same as the prior slide, but inpatient prices is what varies with these dish and medical education prices, not outpatient prices, just inpatient prices. And so you see here that IU Health, when you look at them as a percent of Medicare on the prior slide, they'll look lower, but when you take out their dish, because they do see so many underserved patients and because they are affiliated with the medical school, that their standardized price ends up being quite high, and frankly, the highest. In central Indiana. Now this doesn't look at Parkview Health, and when we did look at it earlier, it was pretty similar. Next slide, please. So quality is king, and we have been talking about for a long time that we don't want to just pay for lowest price. We want to pay for best quality at the best price. And quality is not all the same. So we need to identify how we're going to be more thoughtful going forward around quality. I'm going to show you some information on the CMS hospital star rating. I'm encouraging everyone to spend time with this. This has been around for a long time. It's vetted, it's public, it's free, and a lot of the quality transparency tools such as Empirica and Quantros, they use this data as their backbone. They actually do get, those two companies in particular get the data files. So they, as a research organization, they do get every CMS claim so they can do additional and deeper analyses, but it's from the same set of data, if you will. And this is freely available. And there are over 4,000 hospitals in here. The RAND study has over 3,000 hospitals. If you want to download all of the measures for the CMS Hospital Compare for all of the hospitals, they have various data sets, and you can just download them at that bottom link. Next slide, please. So Chris showed us a slide looking at quality and price as a percent of Medicare, and we wanted to see how our hospitals ranked. So luckily, we have a lot of hospitals. So this is 75 hospitals. So this is looking at inpatient, outpatient facility, and includes professional fees. Now the next slide is going to be inpatient only, and the next slide is going to be outpatient only. And ideally, instead of just looking at star ratings, you would go into the CMS hospital compare, pull out the outpatient measures, line them up with outpatient prices, pull out the inpatient measures, and spend some more time with that. And we'll be doing that going forward. But here's an overview. So this is inpatient, outpatient, plus associated professional fees. The reason the N is 75, even though we had 115 hospitals in Indiana in the study, is a couple of things. One, not all of the fields, because we were reliant on employers giving us data. If the field didn't have inpatient and outpatient, all of our hospitals had outpatient data. So we could say this is what their outpatient prices are, a percent of Medicare, but we didn't have enough claims. We wanted to have a large enough volume of claims before we would post it in the report, and didn't have that for as many. Also, not every hospital, the 9 hospitals, didn't have star ratings, but this is what we have so far. So we don't have hospitals really less than 150, which is what Chris used in his slide. So I bumped it up to less than 200 to 300% of Medicare, and greater than 300% of Medicare. And I might next time just put a greater than 400% of Medicare, because there are some hospitals that are in that space, especially for outpatient. But here you see that we do here in Indiana have some hospitals that are overall low priced and high quality. That's the 4, and I don't know if you guys can see this, but here you have the 4 and the 3. So this is a 5-star. These are 4-star hospitals. These are great. And these are great here too. You can go to the spreadsheet and identify these hospitals. These hospitals are doing great too, but they are more expensive. So we want to, open up the quality measures and see what's going on. But if, we can develop tiers around column 1 and column 2, the low and medium. There are enough hospitals in that space. You can also see that very high priced hospitals in Indiana, we do have some that are in the 2 and 3-star range. So let's split it out. Next slide, please. So this is just looking at inpatient. And as I mentioned, there were only 75, same as the prior slide. And it's similar. Next slide, please. This is looking at outpatient facilities, and now we have our 105, and I mentioned we are actually missing 10 because star ratings aren't reported for it. And this is using 2018 star rating data, but I do want to share that new files have been posted for 2020. And 2020, let's see, Gloria, what was your volume cut? Oops, the chat. I will answer those questions that are coming in here in a moment. So let's see here. What was I saying? Outpatient facility price is 105 because we didn't have 10 with star ratings. But on that link that I provided you earlier, you can download the January 2020 star ratings, and you can see what all the hospital star ratings are. We put 2018 here because these are 2018 prices. This is just really for illustrative purposes, but there are, there are more updated quality ratings. So here's it for outpatient. We have a lot of high quality outpatient, but we have options in the low and medium groups as well. Next slide, please. These next several charts are for your information only. I'm not going to spend a lot of time on it, but what we did is we broke it out by health system just to be helpful for hospitals where we had all of the information. Again, some hospitals, if we didn't have inpatient, then we didn't put it on this table, but you can go to the Excel spreadsheet and find the outpatient. So here you have inpatient, outpatient, facility total, so inpatient plus outpatient. Then you have what the docs get, the professional fees. And then you have all of those columns added up, which is, oh, I see a typo there. It should say facility plus professional. And then here's their Medicare star rating. Next slide, please. And this is for IU Health. Next slide. This is for Community Health Network. Next slide. This is for Franciscan Health. Next slide. This is Parkview Health. Next slide. And this is in Southern Indiana, a couple of hospitals that came per request. Next slide. So change is possible. I've been spending a lot of time talking to different organizations individually about what they might want to do. The biggest thing is for us to have a functional market, and again, we've been talking about this for quite some time, is we need reliable data. And we do believe that RAND is just part of the data that you need, but you need to have prices. You need to have, and we need to do more in the space of quality transparency. We need to make data-driven decisions. So for our benefit consultants and brokers that are out there, you are key to making, helping guide your employers in making really evidence-based decisions. And employers, I would make sure that the data that you're receiving is unbiased and not being impacted by any financial relationships that the benefit consultants may be receiving. Most of our benefit consultants don't operate like that, but there are some. So we need to start holding the entire supply chain accountable by putting performance guarantees. If a health plan, if a benefits consultant, if a vendor that's selling wellness or disease management or sleep or diabetes services, all of these folks that are just selling information, we will start seeing employers start asking for performance guarantees. Again, if a benefits consultant saying, this is, I recommend one of these two on-site clinics or this diabetes service, they need to be held accountable for the recommendations they're making. And the only way you're going to be able to do that is to see if your patient population is improving. And we've had presentations from the Indiana Health Information Exchange where we're looking at population health at the employer level. And I know some employers have engaged them. Some of our health plans, TPAs are engaging them, plus have their own data. And hospitals have direct contracts with employers and are providing that information. So it's really exciting to see everyone starting to align payment with the value of services provided. It's also important to steer patients to high value. And we've talked a lot about that also in the past, but we have to have benefit designs with incentives to align with, that best quality at best price. We also need to do better in our marketplace. This is probably where I see the biggest opportunity for us is payment models. We don't have robust payment models for our providers that reward high value. If we develop these payment models, from my conversations with hospitals and physician groups, they want to be paid based on high value. There's clear opportunity here. And then there's policy. We do believe policy is a lever that we're going to need to pull. And we pulled it last session, got several things across the finish line, and we'll be working on it this session as well. If we do all these things, this is how we're going to start competing on high quality instead of competing on price. So we want to compete on high quality at best price. Next slide, please. So now I'm going to invite Chris Whaley to come back on. We've just got a few slides to share with you what our initial thoughts are regarding RAND 4.0. Chris?
Great. And so we're kind of done with the third wave of this price transparency journey that, again, is really been driven by Indiana employers. And so we have continued to hear from other employers about participating in RAND 4.0 and the opportunity to expand upon our existing studies. And so I both wanted to share some of the things that we're thinking about in terms of where we want to look for RAND 4.0 and some of the questions we want to try to answer, but then also hear from you as employers and really as, again, the innovators for this study on what types of questions would be of interest to you in particular. Next slide, please. So in terms of general timeline, we would like to get data from 2020. And so to ensure full claim run out, I think that's going to put us at about March 2021 as the time point in which we're going to start to get data. And so the way we're thinking of it is essentially use the now to March 2021 period as an opportunity to really get interest from employers, and especially employers who haven't participated in the past studies. And then spend the March through June 2021 period collecting data from employers, health plans, and APCDs. And then with that data, hopefully spend the June to September time analyzing data, following up on any data collection issues that we need to do, and then kind of extend that kind of analysis through October 2021 to January 2022 to kind of make sure a report goes through the review process and gets finalized, and then hopefully share results with you in the late February to early March period of 2022. And we think that that's a period where you'll be done with open enrollment, and then as you're thinking about changes to benefit design for the kind of coming year, that might be an opportunity or kind of an ideal opportunity to have some information on prices. But again, this would be a point where we'd be especially interested in your feedback. Next slide, please. So in the last two or three studies, rather, we really focused on what is the kind of the variation in prices. What we'd like to think was ways to push RAND 4.0 is to think a little bit less about kind of what's just kind of the baseline variation in prices, but focus a little bit more on what innovative employers are doing with this type of data. And we'd also like to kind of peel back the onion, if you will, and to think a little bit more about health spending rather than just kind of this pure price comparison. And so one thing that we'd like to do that I think would be especially relevant to employers is to actually calculate how much could be saved if prices decrease for employers. And so this is something that we've done kind of at a high level, and also for employers who received a private report, something we've done for you as an individual employer. But if we could do something like this at a national level, and for example, say if prices in Indiana came down and reflected more what prices in Michigan are, how much could the Indiana employer population and their workers and their families save? We also want to focus on prices during the COVID-19 pandemic. And this is something that I think the employer community is navigating without lots of data. There is a concern that prices may increase, or that the prices for services that were supposed to be fully covered are not being covered to the same extent. And so we want to actually have some data from you as employers to help inform those decisions and to help you navigate this world going forward. We also want to do more to focus on uncompensated care, essentially charity care for hospitals. As I talked about earlier, we've done some work looking at the share of or the relationship between price and Medicare and Medicaid patient volume, but a similar question is related to uncompensated care. And then our studies have really focused on kind of hospital prices for hospitals, but many patients get care for types of services that can be done in hospitals, but outside of hospital-based settings. In general, these types of independent and non-hospital-based sites of care tend to be quite a bit less expensive than hospital-based sites of care, but we actually want to provide some data to actually inform how different they look relative to hospitals. And so in particular, we'd like to look at prices for outpatient surgeries done in ambulatory surgical centers, and compare surgery or prices rather for surgeries done in ASCs versus prices done in hospital outpatient departments. We also want to compare prices for imaging tests and laboratory services done in freestanding testing centers, and compare those prices to the same imaging and lab tests done in hospitals. And then, as Gloria mentioned, right now we've looked at just professional fees as a whole, and essentially have lumped together professional fees rather for specialty providers and also primary care providers, and having some ability to disentangle that and look at variation in primary care versus specialty provider prices, I think is important. And I think especially focusing on primary care prices will be important. I think there's a growing concern that we kind of collectively don't pay primary care doctors enough, and in terms of the kind of the rising price growth, primary care physicians and providers are not a contributor to that. And so I think having some data to actually document where primary care providers are getting paid differently across the country, but then also just focus on the gap in payments for primary care providers versus specialists will be important. And so those are kind of the ideas that we have on our list. And it would be really great to hear both kind of through either the chat box here or questions, or even just emailing myself or Gloria about questions over the next couple of weeks about other areas that would be interest to you as employers.
Thanks, Chris, so much. So we really welcome everyone's ideas. I know if you haven't had a chance to read RAND 3.0 in great detail, holidays are coming up. It's something fun to snuggle up with. I've enjoyed it, and really great work, Chris, on the report. So we do have a question that's come in, and I'll pose it to you. So what was your volume cutoff to include in the relative price slides that was included on those data tables when we were noting 75 hospitals? So instead of having 115 hospitals for the inpatient, what was that cutoff point on claims?
Yeah, so across the board, we require that hospitals have at least 10 observations to be included in the study.
Excellent. Let's see here. Have the hospital networks responded, specifically Indiana, to this report? That was one of the questions.
Yeah. So I want to answer that question and also Cheryl's question at the same time, in terms of what iteration will be able to actually see some of the kind of the impacts of this type of price transparency. And that's actually one of the things we do want to look at RAND 4.0, because RAND 1.0 came out, RAND rather 2.0 reflected prices through 2017, and so we weren't able to really have kind of a ton of data to look at how hospitals would respond, because that period is already over before we started collecting data for RAND 3.0. If we're able to get data for 2020, we can go back and look at the 2020, 19, 18, and maybe 17 period, and look in the markets where employers have actually had information about prices, and see if that led to any change in hospital prices. And we can also look a little bit more particular at two main, I think, employer-driven efforts that have really come out of this study. So one is the many employers in Indiana in January of this year implemented a reference-based pricing model for outpatient, where pricing care were set relative to Medicare, I think about 200% of Medicare. And so with 2020 data, we can actually look among those employers and see how much that type of effort actually ended up saving Indiana employers. The other effort is that in our previous studies, we've really highlighted some of the outlier prices in Fort Wayne, Indiana, and in particular by the Parkview Health System, which has negotiated a new contract in January of this year. And so if we have some data from 2020, we can actually look at how a kind of employer pressure to focus more on prices that are negotiated on their behalf can lead to changes in prices and spending for the employer community.
So maybe I'll take the question, have hospital networks responded, specifically Indiana, to this report? I mean, they've responded positively. We haven't had any negative feedback on RAND 3.0 at all. The next question is, how do you square the recent interest of direct primary care with the relatively low payments going to professionals, primary care providers per your study? If provider fees aren't the driver, what is? So this is new information for us, and I'm stunned how poorly we pay our professionals. It is terrible that we're paying them 130% on average when we're paying the hospitals 330% of Medicare. This is a problem, and this is a real, like this is one of those aha moments when we think about, how did we get here? Why are 70% of all of our physicians owned by the hospitals? And that's really because they were telling us they weren't getting paid adequately, but no one knew how to benchmark them. What's a fair payment? But now we have this information. And if you go through those tables, you will see that there's a large variability. I mean, some of the professionals are getting paid 160% of Medicare, and some of them are getting paid 107% of Medicare. And I think as a community, we're really going to have to do a deeper dive into the data, start asking some more questions, and readjusting how we're paying our professionals. It's our physicians that are at the front line of COVID, frankly. And I mean, the hospitals are certainly there providing all of the beds and ventilators, but we have an opportunity to do better here. Well, this will be the last.
So just to follow up with that quickly, in Indiana, there is a 200% gap between the average professional and facility fee, and so the way I think we'd square the interest in direct primary care is that if we can leverage that in some sense and say, look, professionals, we're going to pay you more and send more patients to you and give you the responsibility of keeping those patients out of the hospital, then that's a way to save quite a bit, especially in Indiana where prices for hospitals are so high.